So can we start now, ma'am?
Yeah, that's fine.
Okay.
Can I have the slides?
So welcome all to our 11th session. Today we have Dr. SUNITHA Daniel taking a session on gastrointestinal symptoms of bowel obstruction for us. We welcome you, ma'am. So today we are not having Sridevi doctor joining in. She is into some personal emergency. So I think we can start with ma'am's presentation. We can have it for around 40 to 45 minutes, followed by 15 minutes of discussion. Around 4 o'clock, we can have our case presentation, followed by its discussion. We can wind up our session by 4:30. Thank you all for joining in. Ma'am, will you be sharing the presentation or?
I can share if you want me to. You don't have it with you?
I have it, ma'am. Can I share it now?
Yeah, because I'm in a different laptop, so I'll have to email it to this one to get it. I'm in the telemedicine room today,
Okay.
So I'm using their laptop.
Okay. Over to you, ma'am. You can start.
Okay. Thanks, Rajalashmi. Good afternoon to you all. So I think I'll do the second session also. Dr. Sridevi was supposed to take this on bowel obstruction, but I think she's got some emergency. So I'll do a session for you. What I'm planning to is, next slide, please, Rajalashmi. We'll go through the session. It's an important topic, and it's not, it's a small topic also, so we probably will be able to finish on time. And then I've prepared some MCQs also from the previous session. So if you remember, last week's session was a bit rushed off, and I couldn't take it to my satisfaction. So I prepared some MCQs connecting the whole session so that we can discuss in the end. So today's session, I'll start with the case study, and then you can think about that case while I go through the clinical presentation of bowel obstruction. We'll discuss a bit about the management, and then I'll tell you about what we did to the case study in the end, and summary, and then we'll end with the MCQs. Next slide. So we've got a Mrs. JL. She's 55. She was diagnosed with ovarian carcinoma. It was diagnosed in 2010. And initially, she had 4 cycles of palliative chemotherapy. She was stable. She was under monitoring, and it was found that she had stable disease till June 2011. So she did sort of for 1 year, she was going on very well. In June 2011, she presented with increased abdominal distension, nausea, vomiting, and weight loss. They did a repeat CT scan, which showed a disease progression, and which probably shows evidence of subacute small bowel obstruction. So clinically also, when we think of a patient like this, increased distension, nausea, vomiting, we should be thinking about bowel obstruction, especially when a ovarian CA patient. So anyway, CT showed that it showed disease progression as well as subacute bowel obstruction. So think about what will you do next. Next slide. So how common it is. So what is bowel obstruction palliative care? It can occur. How does it occur in palliative care? It can occur either because of functional problem, or it can be a mechanical obstruction of the bowel in the lumen, or it can also be a peristaltic failure. So basically the function of the bowel is affected, or there's a tumor in the bowel lumen or outside. So it can be extraluminal or intraluminal or interluminal, and it can also cause because of the peristaltic failure or paralytic ideas. Also, that is the causes, and also it can be presentation wise, it can be partial or complete. And again, depending on the site of obstruction. So it can be caused due to tumor at any level. So it can be an esophageal cause, or coming down, it can be gastric outlet and proximal small bowel involvement. Or when you come to the small bowel itself, it can either be distal small bowel, and the one is large bowel obstruction. And the thing that we see in advanced cancer patients is commonly they could have multiple sites of obstruction, which can involve both the large bowel and small bowel. Next slide. So why is it important? So it's quite common, we said, and incidence wise, we can see that in ovarian cancer, 42% can present with bowel obstruction. That's one of the cancers. The other cancer is colon cancer. So it can be the primary presentation. So basically, patient won't be having any symptom and can present to the hospital or a doctor with a bowel obstruction. Then you diagnose as a colon cancer, underlying colon cancer, causing a bowel obstruction. It can be a late complication of colorectal cancer in 10% of patients. So 10% of patients with colorectal cancer can present with bowel obstruction in the later stage. So usually if it's a primary presentation, we don't normally get involved because if cancer is diagnosed, so obviously they'll be having a surgery and then, they'll do the biopsy and then they'll do the chemo, etc. And we'll only get involved in the last stage. But normally when there's a late complication in colorectal cancer, we might be involved immediately. Now, other tumors we can present with the bowel obstruction are gastric tumors, pancreatic tumors, cervical tumors, bladder, endometrial, mesothelial of the peritoneum, and melanoma. Okay, next slide. So this slide, it shows the pathophysiology and how the various. Okay, Dr. Annie has said a little louder. Am I audible now? Better?
Dr. Annie, can you hear now? Ma'am, I hope it is clear. You can continue, ma'am.
Okay, so
this slide is soft and clear, not clear.
Okay, so this slide, you can see the pathophysiology and how the various symptoms of bowel obstruction gets presented. So it can either be a partial or complete obstruction. So when we think about the physiology, so we think about the bowel loop when we learned the constipation session last week. So I've seen how the bowel loops work. So there can be when there's an obstruction, there can be reduction or stop in the movement of the intestinal content. So if you remember the last week's presentation, you know that once the intestinal movement stops or the content stops, you can have an increased bowel distension, which causes damage to the epithelium. I mentioned about the neurotransmitters and the enzymes that is released, and that can cause the damage in the epithelium as well as cause the edema and the hyperemia, and it will stimulate the nociceptive mediators, and that can cause a continuous pain. Now, also you can have increased bowel contraction, and when the bowel is not getting moved forward, the content of the bowel lumen increases, and there'll be increased secretions also. So all this gets stimulates, and the the glands will secrete, cause more secretions, and basically when the secretions increase, you can have nausea, vomiting, and you can have colicky pain. So usually when there is when there's increase in the contraction, so there's partial obstruction causing increased contraction, the colicky type of pain comes. So we know the difference between colicky pain and the continuous pain. So patient will be having pain all the time in a continuous pain, and in a colicky pain, we all know it comes and goes. It comes as a cramp, and severe pain comes, and sometimes it settles on its own. Once that cramp or colic goes, it settles on its own. So the importance of knowing which type of pain is basically if you've got a colicky pain, thing to remember is, if you remember the a slide from nausea and vomiting, what I told was in partial bowel obstruction, if there's no colic, we can give perinome or metoclopramide. If there is colic, then perinome or metoclopramide is contraindicated, and we have to give buscopan, which will settle the bowel. So that is an important thing to know. The type of pain is very, very important. And if it's a continuous pain, obviously you can give opioid, but if there's an element of colic there, you will have to add on a antispasmodic like a buscopan or glycopyrrole. So that is the importance of knowing the type of pain. And as we know, because of the pathophysiology, the bowel obstruction can present in both types of pain. So you can even have a continuous pain, or you can also have a cramps or a colicky type of pain. Next slide. So as I mentioned, the inflammatory response can activate the cyclooxygenase prostaglandin, and that will cause the increased secretions. It also causes the release of VIP or vasoactive intestinal peptide, which causes the hyperemia, edema, and again cause increased secretion. Both these increased secretions will cause, it can cause nausea, vomiting, and again that is a role for anti-secretory agents. So we give anti-secretory agents like buscopan or octreotide. It will reduce the secretions and help with the symptoms. Next slide. So what are the causes? At least in palliative care, what are the causes? So it can be because of the cancer. Cancer itself can cause obstruction. So it can be a tumor, it's obstructing the lumen, or it can be treatment for the cancer. So because of if any previous history of any surgery, then you can have additions because of surgery. Previous history of radiation, you can have a post-radiation ischemic fibrosis. So that is related to cancer. The cancer tumor itself can cause a symptom, and the cancer treatment can cause bowel obstruction later on. Now, drugs, we all know opioids will slow down the gut. So chronic constipation can sometimes lead to subacute bowel obstruction. So any drugs like opioids and antimuscarinic can lead to bowel obstruction. Debility, which causes fecal impaction. So again, we learned this bit when we learned about constipation last week. One of the causes of constipation is debility or decreased movement, and that can so frailty and increased tiredness, fatigue, and decreased movement that causes the impaction, fecal impaction that can lead to a subacute bowel obstruction later. And it can be completely unrelated. So patient can be having a strangulated hernia. So again, some sort of incisional hernia, or can get strangulated, and that can present with the bowel obstruction that is not related to the cancer. Next slide. So when it is cancer, it can be a tumor presenting. It can be either the primary tumor or it can be a metastatic tumor. And this can present at any of the sites. So it can be either extrinsic, that means it is outside the lumen. So it can be outside the colon, which can be a tumor growth, as I said, or it can be a post-radiation fibrosis. When it's outside the bowel, so it can be either the growth causing or the fibrosis, or it is a malignant addition. When the bowel loops get stuck onto each other, so it's malignant addition. Be the earliest symptom for small bowel obstruction, and there'll be large volume vomiting, and it'll be frequent because they'll have to, the symptom comes quite frequently in case of small bowel obstruction. Now, if you come to large bowel obstruction, so when it comes down, usually what we say is the emesis develops later. So vomiting is a late symptom, and when it reaches, so it starts with constipation and abdominal pain. Vomiting is a late symptom, and when it reaches a symptom of vomiting, it's usually fecal and vomiting, because obstruction has gone so high up that there's a fecal and vomiting. And sometimes you can also have a gaseous abdominal distension. So when we examine the patient, you can have features of a gaseous abdominal distension in a large bowel obstruction. Next slide. So how do you manage a patient with malignant bowel obstruction? And as far as we know, it's the greatest challenges for palliative care physician. One of the difficult symptom that to manage, especially the vomiting bit, is sometimes very, very difficult to manage. When you plan for the treatment, usually the type of obstruction, then how well is the patient? The condition of the patient is very, very important, and the predicted prognosis, because there could be a role for surgery in these patients also, even though they are palliative and sort of not from any further active oncological treatment. For symptom relief and for the purpose of you could actually take surgery for them. So you have to carefully select the patient. The condition of the patient is very important, and the predicted prognosis will determine the treatment plan for the obstruction. So you have to carefully assess the patient, check for everything. If you do a surgery for the patient, will they be able to cope with the surgery? Will they be able to, are they fit enough for the surgery? Will they be able to have a wound healing? And all those things are important when we decide if the patient is fit for surgery or not. Next slide. Our goals of game would be to first is relieve of symptoms. So we're not doing anything to prolong the life. When we get a patient like this, so this is for a patient who is sort of end stage end stage present of the bowel obstruction, not the first presentation. So in this case, we're not doing anything to prolong life. Our goal should be to relieve of symptoms, and on top of that, we also allow adequate nutrition and hydration. So we don't even if it's a hospice setting or in a palliative care setting, we don't usually go with a strict nil by mouth. If your patient is continuously vomiting, then obviously giving food is not in the best interest. But if the patient feels that they want to feed, then we don't actually say them to be strict nil by mouth. So allow adequate nutrition and hydration. Permit oral feeding if when possible, because some people might be hungry. So we do methods to sort of improve the obstruction via medical methods. They're not fit for surgery, and then but they still want to eat. We do permit it depending on the symptoms. So permit oral feeding when possible, and try and improve the quality of life. Next slide. Investigation. So what all do you do to for a patient who presents with bowel obstruction? So blood investigation, the most important thing would be, you could do all the routine blood tests. You can look for anemia, you can look for infection, and if you're planning for surgery, definitely do the full set of bloods. Albumin is very important because the patient is going to get, how are they going to tolerate the surgery? How are they going to get better after surgery? So healing is very important. So albumin, all the other parameters are important if you're planning for surgery. But the important thing to look about is hypercalcemia or hypokalemia. Because hypercalcemia can cause constipation, which can lead to bowel obstruction, and hypokalemia can cause paralytic idea. So these two blood tests are important. Correctable things. So if you think there is something correctable medically going on, you could actually do these two blood tests to see to manage them. Consider abdominal X-ray. Again, Abdominal X-ray, you can see the air fluid level. Sometimes you can just see plain chronic constipation there, or in classic bowel obstruction, you can see air fluid level. And if I think what I would say consider abdominal CT only would be maybe if you're planning some surgical intervention. If you think the patient is fit enough for a surgical intervention, definitely we can consider abdominal CT, because whatever we do, whatever, our basic motto is, if the patient is under us, palliative care, then we wouldn't do an unnecessary investigation unless there is something that is going to change the management. So one, we could diagnose it, but then if you feel that there isn't bowel obstruction and there is a surgically amenable, then it's, we have to do an abdominal CT and contrast study to find the site of obstruction. Next slide. Okay, surgery. So as I said, some patients we can consider surgery. So when do we consider surgery? The surgery should always be thought about in a carefully selected patient, and surgery can provide relief of symptoms for a significant period of time. So sometimes they might, if you don't do a surgery, it might be a very difficult symptom to control, and with poor quality of life, and obviously they're going to probably die with the electrolyte imbalance and ongoing vomiting and everything. So if in a carefully selected patient, sometimes surgery can provide relief of symptoms, and that too for a significant period of time. So when do we consider, or which all patients you can consider for a surgery? Suppose it's a single or discrete organic obstruction like adhesions, or where there's an isolated neoplasm, you can just remove the tumor and then probably they're fit for surgery. Good performance status is very important. So whichever measurement you use in your unit, do a performance status. You can either do WHO performance status or a Karnofsky's performance status. Any tool that you can use, you should use that to find the performance status of the patient. And patient should be willing to undergo surgery. Obviously, you need the consent of the patient. Sorry, somebody is talking. Sorry, the slides are going. Can we come back, Rajashmi? Previous slide. Okay. Is everybody muted other than you and me? Because you need to mute your side if you're not talking, if you're not speaking. Because there was some disturbance coming on. I don't know from where it came.
Hello, can you hear us now?
Yeah, I can hear you.
But we can't hear any disturbance coming in. We will see. We can continue.
You couldn't hear any disturbance coming from anywhere? Oh, okay. I could hear people talking.
What about rest of our participants? Is there any disturbance in between?
Okay, that's fine. Consider surgery if good performance status, and patients should be willing to undergo the surgery, and there is no disseminated disease everywhere, and patients independent, active, and the weight loss should be less than 9 kilos. So obviously the patient would have some weight loss, and it shouldn't be more than 9 kilo. If it's more than 9 kilo, then probably they're not a good candidate to go in for a surgical candidate. Next slide. What are the contraindications? So to consider for a surgery, what are the contraindications? So if the patient has had a previous laparotomy done, and the findings will preclude the prospect of a successful intervention. At that time, you had opened up the patient before and had decided that actually, even if this patient has got a bowel obstruction in the future, we're not going to intervene, or there's no point, you can't successfully intervene in such a patient. So such patients, or those who are known to have a diffuse intra-abdominal carcinomatosis, massive ascites. So they can have two symptoms. Basically, patient will be having ascites and patient having bowel obstruction, but the massive ascites can reaccumulate rapidly after paracentesis. So even if you do surgery for the obstruction, the ascites is still there, and that is a contraindication to do an active surgery. Presence of reobstruction. So they already had an obstruction before it was managed, maybe was surgically managed, and now it's a reobstruction. You can have multiple palpable masses. So it's not a single tumor, it's a multiple tumor. Poor nutritional status, and this is an important thing to do the albumin level. So I've had a patient who's had a similar scenario, bowel obstruction, come in, and she sort of had a symptom of bowel obstruction going into total. We could have managed with a medical management. Unfortunately, she ended up going to surgeons first, and they did a surgery for her, just a colostomy, just for as a palliative measure. But her albumin was only 1.5, and she didn't survive the postoperative period. She died within 2 or 3 days, and I think she would have lived longer if we had got involved and surgery was not done. So that is the thing. If the patient, even if you're managing the patient, they should be able to tolerate the surgery. And I think albumin is a very good indicator of the nutritional status. If it's a poor nutritional status, please don't consider surgery. And poor general performance status. And obviously the patient refusing to undergo surgery, then you can't do a surgery on them. Next slide. What are the types of surgical management we can do? You can do I think surgeons will be better able to explain to us. So basically, one is a bypass surgery where there's a tumor there, you bypass the obstruction and put them together, or like suture the bowel together. You can do a stenting, which can be gastric stenting or a rectal stenting, and we can also do a bending gastrostomy procedure. I think there's lots of surgeons in the group, so you might be able to explain to us what these procedures are better. Next slide. Yeah, these are some of the slides. So this is how the colostomy look. And colostomy care probably would be a different topic, but we get involved a lot of our patients actually post-operatively. Once they get a surgery done and once they have a colostomy, then the changing of the bag, managing of the colostomy, wound and stomach care, all palliative care team gets involved in that, especially the nursing team gets involved in that. So you open up the bowel and do a suturing, and end-to-end anastomosis is done for the bowel, and that's how, and you bypass the whole tumor. Next slide. What are the ways in which you can medically manage the patient? So the most important thing is you talk to the patient and the family. You have to tell them ongoing information about and also give psychological support for the patients and the family. We tell them that ideally this patient should be having a surgery, but because the condition is she's not fit enough for a surgery, we're doing in medical management, which means that it might not be accessible as a surgical management. So the symptom might still be uncontrolled. Focus on treating the predominant symptoms and review the treatment. Whatever treatment we start, review it regularly as the symptoms can change. People can have either worsening of symptoms or symptoms can get better. So keep on reviewing the treatment. Always, if the patient is having a bowel obstruction, even if they're not vomiting, if they're having bowel obstruction, it's unlikely that the oral medications will be absorbed, including the pain management. So we realize that if you give oral morphine, the pain is not getting any better, and then you have to give via IV or a subcut route. So it's better to at least give rest to the bowel, medications wise. So you can put a syringe driver, a subcut driver, and you can give all the medications via the syringe driver. You can either use subcut or IV fluids, might be required for hydration and for electrolyte balance as well as for comfort, and always look after the oral hygiene. So good and regular oral hygiene is also important. Next slide. What are the medications we use for management? So depending on the symptoms. So we mentioned what are the symptoms, nausea, vomiting. So you have to go for antiemetics. For pain management, continuous pain, you go for opioids. Look at the laxatives. If they're constipated, then you have to give them laxatives, stronger laxatives. Steroids, dexamethasone, 16 milligram dose is something that we quite often give in palliative care, especially for patients who are not fit enough for surgery. If there's a tumor or additions, it is known to reduce a tumor edema. So we give high dose of steroids, subcut, for quite a few days, and then gradually reduce the dose. Anti-secretory drugs include the hyoscine, buscopan, and octreotide, which can be used for that. And NG-tube is indicated. So NG-tube is basically if the obstruction is quite high up and there's lots of secretions, lots of vomiting going on. Whatever you give the patient's vomiting out, and it's and whatever we do, the symptom-wise is not getting any better. You can put a large bore NG-tube in for NG-tube drainage. Now again, it is careful patient selection is important because it's not a pleasant procedure, but we do it for feeding purposes. So if it's possible, and sometimes what I've done in some patients is they badly want to eat, so whatever they're eating is coming out. But then what I've done is I've put an NG tube down and connected to free draining, and then the principle is whatever you eat by mouth will come to stomach and come out to the NG. But still, because we're not able to control that, we're giving all the medications, it's not getting under control. So what we do is we let the patient eat, knowing that nothing is going to get absorbed. It's just comfort eating. They're eating because they want to eat. And you put an NG down and maybe connect it to the drain, NG free draining, and it's whatever accumulates comes out. Next slide. If it's a complete obstruction, then it's better to stop all the laxatives orally, and you can clear the bowel with a phosphate enema. So you can give an enema and clear the bowel. If it's a colic, the pain type of pain is colicky type of pain, you can give antispasmodic medications and anti-secretory. So you've got buscopan, that's hyoscine, butyl bromide, 20 mg subcut stat, and you can give 80 to 160 milligram up to 160 in 24 hours as a syringe driver infusion. If it's hydrobromide is available, it's a different dosage for that. Again, also works as an antiemetic. And some places use glycopyrronium as 400 microgram. Syringe type of sedation is to be avoided. Some units prefer glycopyrronium, but either way, it's fine. You can either use buscopan or glycopyrronium. All these are anti-secretory. The thing to remember is it can actually worsen constipation also, but you can try and clear the bowel with phosphate enema. Next slide. If it's a partial obstruction, this was mentioned in my nausea vomiting slide. So it's perinome. So you try something that is a gastric stimulant or prokinetic. So if you give a prokinetic, so you can get metoclopramide. Again, dosage, you start with 30 milligram. You can maximum you go to 90 to 100 milligram over 24 hours. Higher than that, there isn't much benefit. Always watch for extrapyramidal symptoms, especially when we go for high dose of perinome. This dose, you can only give it as a syringe type, a continuous infusion over 24 hours. Always remember that if it's a complete obstruction, you can increase the colic and cause vomiting and complete obstruction. Dexamethasone, the dose we normally go is, I usually give 16 milligram, but range is 8 to 16 milligram daily subcut, 5-day initial trial. You give for 5 days. If the symptoms is not getting any better, then just stop it because it's not going to work. So give it for 5 days first, and then you can stop it. And you can start it for high level GI obstruction, gastric outlet obstruction. Ideally, it's suggested for high level obstruction and for lymphoma because tumors will respond to steroid. But for all the patients who present with bowel obstruction, if there's no contraindication to give steroids, we usually give high dose steroid for at least 5 days. Next slide. Continuous pain, you can give opioids, and again, it'll actually calm the gut down. So basically, if it's a cramping, colicky pain, then it's a dual effect. It treat the pain directly and also reduces the gut motility, as we know opioids do. So you can give it for continuous pain. And sometimes NSAIDs, and here the NSAID that we use has to be a parenteral one. So you can give either ketorolac, ketorolac and a subcut NSAID. You can give 30 milligram, a maximum to 120 milligram can be given on 24 hours. So ketorolac also can be given as an infusion. Diclofenac can be given as IM. So whatever is available as a parenteral preparation, you can use because orally it's not going to work. Next slide. Vomiting. Combination of antiemetic sometimes may be required. Again, remember that if it's a peristaltic failure, a prokinetic, you use metoclopramide. Now, if you remember the slides that I took last session, you don't give metoclopramide and cyclizine together because both are antagonistic at the end. So once you give a metoclopramide, then don't add cyclizine to that. If the metoclopramide doesn't work, you stop the metoclopramide but give cyclizine. But you can give cyclizine and haloperidol together. So normally, if it's a total obstruction, complete failure, colicky pain, you start with cyclizine, 150 milligrams subcut over 24 hours. Then you have haloperidol to it, 1.5 to 2.5 milligram, maximum 10 milligram over 24 hours. Levomepramycin again is a broad spectrum antiemetic. It's not available here, but instead of that, we use olanzapine. Now, levomepramycin is available as a subcut form. Olanzapine, as far as I know, is only available as oral medication. We need to check that. You can also add ondansetron. So sometimes it doesn't work with one. And if you remember the class from last week, it's all different receptors. We're trying to cover all the receptors. If it doesn't work with one, sometimes you have to add antiemetics to it. So things. What all can we try? You can try cyclizine, haloperidol combination. You can add levochlorpromazine or ondansetron. The thing to remember with haloperidol, levo, and metoclopramide is extrapyramidal side effects. So all these three can cause extrapyramidal side effect. So if you combine them together, then always watch for that. Normally, if you're going in the levo route, then we stop the haloperidol because haloperidol and levo has the same receptors. So there's no advantage in giving the, normally if it's going to levo route, then you just leave them on levo alone. You can add ondansetron to it because ondansetron has an additional receptor coverage. So always think about the receptors when we give the antiemetics. So if the one antiemetic has got a cover of all the receptors, then just stick on to that rather than give them together, but add the additional ones. So perinome metoclopramide has a prokinetic effect also, so probably you can give it with levo. But the thing to remember is that can cause extrapyramidal side effects. So always remember about the side effects also. Next slide. Again, repetition. So patient without colic and passing flatus, prokinetic first is a drug of choice. So if it's passing flatus, that means it's not a complete obstruction. We all know that, right? So if it's a patient with colic, then you give an antisecretory and antispasmodic drug like a buscopan. To be aware of the anticholinergic effect of some of the drugs that we normally give, which can inhibit the gut motility. This was mentioned earlier on. That is why some drugs can cause constipation. Next slide, please. Octreotide, I've again mentioned this in the nausea vomiting class. It's a synthetic analog of somatostatin with a longer duration of action. And it's an inhibitory hormone. It's normally present throughout the body. It inhibits the release of growth hormone, TSH, prolactin, and ACTH in the hypothalamus. So it can cause the inhibition of the release of these hormones actually can cause some of the side effects of octreotide if it's given in the long term. And it also inhibits the peptides of the gastrointestinal and the endopancreatic system. Next slide. Now, octreotide, there has been some study done on the use of octreotide and bowel obstruction. Now, what they have found is less than 50% of patients respond to the typical starting dose of 300 microgram of octreotide in 24 hours. Now, normally we start with 300 microgram in 24 hours, and then once you increase the dose, 75 to 90% respond to 600 to 800 microgram in 24 hours. And they've done a trial where they compared buscopan with octreotide. And so what they found initially, this is just like the one that I described about haloperidol trial. So octreotide will cause a more effective and rapid relief of nausea and vomiting and reduce NG output. So one arm of the trial, they gave buscopan alone, buscopan cyclizine, and the other one, they gave octreotide. And what they found was octreotide was more effective and caused a rapid relief of nausea, vomiting, and reduce NG output. But after that is immediate one. So immediately the octreotide works better, it's quicker. But after 4 to 6 days, overall symptom comparison was similar. So how they found that was they used the rise tube aspirate. So the amount of aspirate was coming in every 24 hours. They found that the octreotide arm had a lesser output in the first 24 hours, but when you reach 4 to 6 days, both the drugs has got the similar effects. The thing to remember is obviously octreotide is expensive. And if you've got buscopan and cyclizine combination, then overall it's as effective as giving octreotide. And lanreotide is an alternate sandostatin analog, which is available in depot preparation. That is given as an injections, either a deep IM injection or it's as a depot preparation. It's a long-acting one, but not for our palliative care patients. Next slide. There's also mentioning of use of octreotide, and this PCF palliative care formulae actually reports this. You can use octreotide for ascites. So there's a malignant ascites, and the mechanism how it acts is suppressive diuretic induced activation of the renin, aldosterone, angiotensin system. So if your patient is already on diuretics, and if you give octreotide to the top of that, then you can actually improve the efficacy of diuretics in cirrhosis. And it can also interfere with the ascitic fluid formulation by reducing the splanchnic blood flow as a result of direct tumor anti-secretory effects. So basically, it's the anti-secretory effect. It decreases secretion, and so it's shown to have some benefit on some patients with malignant ascites that's reaccumulating very, very quickly. And you can give it along with the diuretics if the patients are on diuretics. Next slide. What are the undesirable effects from octreotide? Sometimes a bolus subcut injection is painful. Some patients, it can cause a dry mouth, flatulence, nausea, abdominal pain, diarrhea, and impaired glucose tolerance and gallstones. These are some of the reported side effects of octreotide. Next slide, please. Again, because of the action of various hormones and enzymes, so you have to be cautious using insulinoma, type 1 diabetes, cirrhosis patient, renal failure. And if the patient is on a short-acting octreotide for a long time, avoid the heptide withdrawal. So you have to reduce the dose and stop it, and always monitor the thyroid function because it affects the TSH also. Next slide. Interventions I mentioned before, depending on the level of obstruction, you can try stents and venting gastrostomy. Next slide. So what has happened to our patient? So our patient initially, so when she came to the hospital, so she wasn't suitable for any surgery and intervention. So she didn't have any colics. So we trialed her on metoclopramide as syringe driver. It was not effective, so that was converted to a levomipramycin syringe driver, 12.5 mg over 24 hours. And she continued to have ongoing large volume vomitus. So we had to add octreotide added to the syringe driver. We had to go with 1 milligram. So basically started with the 300 milligram and then dose increase, and we went to 1 milligram over 24 hours. And this actually stabilized the symptoms and allow for periods of at least 6 weeks. She had a 6 weeks. We managed to discharge the patient. I think because syringe drivers is quite popular in hospice, we can start the medications in the syringe pump, and we discharge the patient with syringe pump, and the district nurses will go and check the pump every day. So every day the district nurse will have to go and refill the pump. So that is possible that we can get some quality time at home for the patient. So this patient, obviously, I think if she had gone the surgical route, probably wouldn't have survived the surgery because she was not a fit patient for the surgery. But we were able to manage the symptoms medically, and she got 6 weeks of quality time at home with the family. Next slide. Always consider changing to, if the patients become stabilized and the symptoms are controlled, then you can consider changing the drugs to oral drugs. And as I said, encourage the patient to have favorite beverage and food at home, and pay attention to oral hygiene. Next slide. So to summarize, it's one of the challenging problems in palliative care, and the focus should be to improve the quality of life. If there's a focal obstruction, consider the possibility or suitability of intervention. And usually this rarely needs IV fluids or NG tube to relieve symptoms. Sometimes we have to give that. Reduce the vomiting, pain, and the volume of the intestinal contents. And depending on the condition, you decide which medications you are going to try. And there is a role of subcutaneous hydration. If the patient you think is clinically will need some fluids, then you can give some subcut fluids. Next slide. Okay. Now I've got a few questions, 5 or 6 questions. If you can, it's just very simple MCQs. If you know the answer, you can unmute. I probably will give you about 10 seconds, 10, 15 seconds. You can unmute and say the answer, and then we can go on. So this is from the last week's presentation. So if you remember slides, which drug is used first line for the metabolic cause of nausea vomiting? Is it octreotide, ondansetron, haloperidol, or cyclizine? Anybody?
Just unmute from your end and shoot the answers.
D, cyclizine.
No, ma'am, that's not the answer. Anybody else? Okay, so the drug of choice for metabolic causes haloperidol. Next slide. So if you remember from the last week's presentation, basically it was the blood-brain barrier receptors in the blood-brain barrier. So metabolic causes. So haloperidol was the one that acts at the blood-brain barrier. CT is a chemoreceptor trigger zone. So normally, you could give any antiemetic for any cause. So if you specifically think it's a drug-induced metabolic cause, so uremia, or if it's a opioid causing, normally we go with haloperidol as the first line. You could give anything and it might work, but as I said, specifically what we think of is haloperidol as first line. Okay, next slide. Okay, vomiting due to gastric stasis. What is it? Drug of choice. Is it metoclopramide, cyclizine, ondansetron, or aprepitant? Anybody?
Dr. Annie, can you unmute and speak?
So which one works as a prokinetic or for gastric stasis? We discussed this today also and last
Dr.
week.
Jessie? Ma'am, can you repeat it once again?
Metoclopramide.
Metoclopramide, well done. So next slide. So metoclopramide is a drug of choice when it's a gastric stasis is involved. So prokinetic effect. Okay. Which one of the following is an NK1 receptor antagonist? Is it metoclopramide, cyclizine, ondansetron, or aprepitant?
Anyone?
Cyclizine.
NK1 receptor. NK1 receptor. Cyclizine is a H1, histamine 1.
Okay.
NK1 receptor is a new antiemetic that people are using for chemotherapy now. NK1 receptor. Okay, it's aprepitant. Next slide. So as I said, aprepitant is D is the answer. Somebody has put us a message. D is the answer for that. So it's aprepitant. That's a newer antiemetic that has now been used for the chemotherapy, very severely emetogenic chemotherapy. It's an NK1 receptor antagonistic. It's aprepitant. Next slide. Which of the following is an osmotic laxative? Is it lactulose, isoflurane, liquid paraffin, bisacodyl?
Dr. Jessie?
Liquid paraffin.
No.
Bisacodyl.
No. It's lactulose. So lactulose is a fully osmotic laxative in that group. Next slide. So lactulose is the one that is drug of choice for not just palliative care. We all studied that for liver failure also. Hepatic encephalopathy, they use the osmotic laxative. So lactulose is the osmotic laxative in the group. Bisacodyl is a stool stimulant. The other one, liquid paraffin, is a surface weighting agent. So osmotic one is a lactulose. Next slide. Which is a drug of choice for opioid-induced constipation. So this is not available in India, but I did mention it in my last class. Specifically, in India, we wouldn't start this, but specifically as a theoretical basis, which is the drug of choice for opioid-induced constipation.
Dr. Pyrina have mentioned D, Bisacodyl.
No. Bisacodyl and Senna is one that we start here, obviously, but for my last week's class, it's methyl naltrexone. Next slide. Methyl naltrexone is the drug of choice for if it's an opioid, because specifically for opioid, it is an opioid antagonist. If you remember from the last week's presentation, it's a specific opioid antagonistic which works on the gut receptors alone and not on the pain receptors. So specifically, we can give obviously in our setting we'll start bisacodyl because that's the only one that's available for us. So we need a stimulant laxative for that. But if it's not working and then we have to give something, then if you've got methyl naltrexone available, that is the one that we give for opioid-induced constipation. Okay, next slide. Okay, this is from today's slide. So all the following are indications of surgery for bowel obstruction except single discrete organic obstruction, good performance status, patient willing to undergo surgery, and multiple palpable masses. This is from today's class. All the willing. Yeah, I think Dr. Sister has answered correctly. D is answer. That's multiple palpable masses. So all the others are, indications of surgery except for multiple masses. Next slide. Then it's not an indication for surgery. I think that's the last one. Next slide. Yeah. So any questions, you can ask me now, or we can go to.
Thank you, ma'am, for the wonderful presentation. Now, any questions or comments on bowel obstruction? You can raise your hands. We can unmute you. Dr. Jessie?
Yeah. Ma'am, very nice class. So
Thank
many,
you.
in our daily practice also very useful topic. I just wanted to clear my doubt on this. Your slide was saying patient without colic and there is passing of the flatus, then we use prokinetic drugs.
Yeah, so that means it is there's no colic and this passing of flatus means there's not complete obstruction, right? So partial obstruction, we can use a prokinetic like metoclopramide. If there's a colic, we can use metoclopramide.
Okay. One more doubt, ma'am. Subcutaneous hydration, your slides mentioning. I'm new to that word. Subcutaneous hydration means?
So no. In palliative care, you must have seen that we always say subcutaneous. So we give, we give something called CSCI, so continuous subcutaneous infusion. So in palliative care, all our nurses are trained to put a subcutaneous needle in, so that we put a butterfly needle, either just like giving insulin. So basically, you pull the skin up and put the butterfly needle, and you tape the butterfly needle to the skin. You can put it in the forearm, sometimes on the chest, back of the chest, on the thigh. And all our medications in palliative care, all the medications that we use can be given as a subcut route, including steroids. Dexamorphine, haloperidol, midazolam, all our medications we give as a subcutaneous. On top of that, the reason we go for that is, one is anybody can do it. You can do it at home. Even the family can do it. Not a traumatic procedure, not a painful procedure for the patient. You don't need a cannula. And you can do it at home. That's the reason we go for that, if you have to give parenteral route. So similarly, we can give fluids also like that. So it's called, I think it's called dermoclolysis. If you Google that, basically it's giving a saline. The fluid that we give is normal saline. We can't give dextrose, but we give normal saline as a subcutaneous infusion. So you put a subcut needle in, you connect it to the IV bag, and then it goes very, very slowly. So it goes over 12 hours, but we can give one bag or 2 hours like that. So if the patient is being managed at home and needs some hydration, we can go with the subcutaneous infusion fluids.
Okay, thank you.
Thank you, Dr. Jessie. Thank you, ma'am. Anyone else? So if you are not having any comments, can we move on to the case presentation now? Dr. Lillis? Ma'am, can you hear us, Dr. Lillis?
Yes, I can. Can you hear me?
Yes, ma'am, yes. So
Okay.
you can start your presentation, ma'am.
Okay.
Thank you.
Okay, good afternoon to all. I'm Dr. Ladies, working in Jivalan Hospital, Larati, Telangana. I'm in a village setup. Since 40 years, I'm working in this village. My today's case is,
Ma'am, 1 second. Can everyone see the slide share? Can you raise your hand if you can? No, you can't. 1 second. I will
Can't see.
share it again. I will share it again.
okay. Hello.
Ma'am, 1 second.
Okay.
Yes, now we can see.
Okay, ma'am, you can continue. Dr. Hardik?
Okay. The 46-year-old female diagnosed as carcinoma colon with metastasis to liver and brain and admitted in our hospital with the altered sensorium, severe anemia and constipation that I'm not mentioned here. Presenting complaints were breathing difficulty, fever since 1 week, difficulty in taking orally, constipation, abdominal discomfort, and altered sensorium. History of illness. As reported by the husband, patient was all right till February this year. Then she developed indigestion, mild abdominal gaseous distension after food intake, and she treated with the counter supply medicine, and she was better. Then she developed diarrhea after food, diarrhea altered with constipation. She consulted the nearby MBBS doctor. Medicines advised for her symptoms. She felt better. No abdominal scan or any investigations done. She was so worried about the forthcoming marriage of her first daughter. Then all of a sudden, in the month of July first week, she fainted and collapsed. Taken to hospital. Among the initial investigations, MRI is done and diagnosed as carcinoma colon with liver and brain metastasis. They are told that it is too late for any treatment and they can take her back home, and some general tonics and the protein powder advised. In desperation, family took the patient home and turned to home remedies or country practices. They promised complete cure. Some improvement was there in the beginning in appetite and bowel movement, but her condition worsened in a few weeks, and they brought the patient to our hospital for symptom management on 5/8/19. Examination. Middle-aged lady, thin built, poorly nourished. Patient is in altered sensorium, responding verbal commands. Tongue pale and dry with whitish gray membranous patches. Febrile, BP 130/90. Heart sounds normal, no murmurs. Lung bilateral air NB plus bilateral basal crutch. Her abdomen soft, distended, mass palpable in right hypochondrium and central abdomen below umbilicus. Mild edema of pitch. Treatment and significant investigation. On 6/8/19, investigations. RPS 139, ECG normal, HB 8.3 grams per cent, CC 20,000 with a shift to left. Neutrophils 88%. Total protein 5 grams. Malaria and parasites negative. Serum electrolytes normal, and it is tested alternate day. Every day found almost normal. Blood sugar on 10/8, blood sugar 224. Blood urea 70 grams and serum creatinine 1. Repeated alternated day. Almost found normal. Psychosocial aspects. Happily married with 3 grown-up children, all doing college studies. Husband businessman, economically sound. Very loving and caring family. Preparations for the marriage of the first daughter. Over anxious about the daughter's marriage, as if she is only a responsible person for that. Medications. On 5/8/19, patient is put on oxygen inhalation, IV fluids, Backrest, urinary catheter, and bile tube insertion done. Injection pan for 40 mg IV, injection AMOL 100 mg IV for temperature. Jab scan, full scan 150 mg is given. Candid mouthpiece is applied. Jab oral iron tablet is given. Protein powder is applied. On 6/8/19, injection Duratas 4.5 mg in 75 ml BD. Injection Laxis 1 ampule IV twice daily. On 14/8, Astellin Mensna in nebulization and the Epcorian 100 mg IV with insulin. Main concern. Delayed detection of cancer of colon caused total bowel obstruction and other complications in an young lady. Lack of medical conscience and knowledge and responsibility of general practitioners and an unempathic way of communicating the bad news leads to untimely death of a mother. Over anxiety of the patient for the marriage of her daughter might have contributed as an aggravating factor. Summary. 46-year-old female diagnosed as CA colon with metastasis of liver and brain with altered sensorium, breathing difficulty, constipation, unable to take orally, oral candidiasis, highly anemic with abdominal distension due to fluid, is admitted on 5/8/19 and treated for symptoms for 10 days. Pain was not a major problem as she was in altered sensorium. After 6 days, patient had a paralysis of right side. Symptoms did not improve. Patient died on 14/8/19. Main concerns.
Ma'am, you can read out the discussion points.
Okay. Discussion points. Bowel obstruction is very common in CA of elementary system. How can we prevent or at least detect or at least delay this? Second, can we determine the area of obstruction from the signs and symptoms? Is it possible early detection? If so, what are the symptoms of manifestation and how to detect it? What is the place of surgical intervention for removal of the obstruction? Has the dietary habit got any influence on the bowel obstruction caused by CA? These are the discussion points.
Thank you, Dr. Lellis.
Thank you.
So before moving to Dr. Sunitha on the presentation discussion points, I wish to talk to our participants on their experience having a patient with cancer in alimentary canal systems and all. So anyone wishes to answer like your experience with a person?
Yeah, yes.
Yes, doctor, you can speak.
Yeah, most of the times the cancer of the alimentary canal is detected in the late stage of disease. Already metastasis has taken place. Therefore, the treatment is very difficult. Most of the time on the third or fourth stage of the disease, it is detected. And by the time metastasis already has taken place, surgical intervention is very poor. And the treatment, chemotherapy, mainly the patient dies off in 6 months' time. Usually, that's what we have seen. I have seen lately.
Thank you, Dr. Vinaya, for sharing your experience. Dr. Sunitha, your say on that question?
It's the first question, right?
Yes, ma'am.
Okay, so I think it's the same as what I said in my presentation. Some people it can present as a presenting condition, as a obstruction, but you know, when it comes to us, usually it's very late, and it's difficult to it's a difficult symptom to manage. And so yeah, I agree with what Dr. Sister said.
Thank you, doctor. So can we determine the area of obstruction from signs and symptoms? Dr. Sunitha, you
This I had mentioned in my class. Yeah. So, you know, one slide was showing about if it's an ideal obstruction. So usually if it's a higher up obstruction, so you can have vomiting earlier on and probably constipation later on. And then if it's a colonic or lower down obstruction, sometimes it's vomiting is a late presentation, starts with constipation. And once it becomes feculent, once vomiting starts, it's usually feculent vomiting. So that's the only thing that basically with ileal come or it's a colonic obstruction. We can know it from that.
Ultrasound also can be diagnosed.
Is it possible for early
Scans.
Dr. Sunitha? Yes,
yeah
ma'am.
yeah ultrasound usually the investigation, I think abdominal X-ray is quite a good one, you know, that air fluid level will be clearly be seen in that, and constipation also. Ultrasound sometimes to know the bowel, it's sometimes it's not very good as far as I know. We have to go with CT abdomen. And you know, CT with contrast study sometimes is needed.
Irregular thickening of the bowel walls. That is one of the suspicion of CA. Early detection.
Early detection of CA. You mean a mass? Okay. By ultrasound. The other thing to know is the patient quite young? Whether there's a family history of cancer in the patient, and when she had the symptoms earlier on, her symptoms were like a bowel symptoms, wasn't it, in February? So whether it should have been investigated further on that, you know, fecal occult blood and all, colonoscopy and fecal occult blood, was any possible to do that?
Dr. Lellis?
Yes. Hello? Yes. Hello.
Hello, madam.
Yeah, ma'am. Yeah.
Can I conclude? Hello.
Yes, ma'am. We can hear you. You can say, ma'am.
In this case, actually, this patient had symptoms early in February, 4 or 5 months back. Problem of our village setup, probably all over India, is these symptoms we are not giving proper meaning, proper importance. We will do self-management. Or even our local doctors take it easy. If she was having a scan or a CT, something like in February, there was quite enough time for her to get treated, probably prolong her life. That's my feeling. And I get some experience of other cases, also whether the same problem. Early symptoms, the patient will ignore it, or the family also. Okay, some antibiotic, fluctuance over some digestive and appetite is increased. Like that is happening. Altogether in India, that is the condition. Can we do anything there in that sense? Sensitize our people to attend for the early symptoms of cancer.
Yeah, this is an important thing that I am getting involved in my state now. So I'm doing a bit of community oncology in a job where I'm involved with early cancer detection. But right now we're really concentrating on 3 important cancers, which is breast, cervix, and oral cancer. Mainly because, some symptoms do, we all know symptoms can come up early for these patients. And it's early we pick it, it's, easier to treat and, treat and diagnose such.
Dr. Sunitha?
Hello.
Dr. Sunitha, can you hear us?
Have a guideline about doing colonoscopy. Depending on the risk factors, isn't it? So some people, they do yearly colonoscopies if there's a family history. And then the other one is the stool occult blood. So that's a screening test. So is that possible for us to do that in our community, in our setup? That is something that we need to think about. But other cancers like lung cancer or ovarian cancer and all, sometimes the presentation is quite late. So whatever we try to do, whatever screening do, sometimes we might not be able to pick it up. So the important thing is to actually create awareness among the public about the how can we detect it, and one is the dietary modifications, all the risk factors, how can we prevent that, and how do you pick up these cancers earlier on. And colon is it's coming in the younger population now. It is very, very sad. I have also seen a few of the colon cancer patients who die, who's only like 28 and or much younger than us, and sadly dying because they too unfortunately aggressive when they come in the younger population, and and it's, we can't do anything. They present quite late, so present as a bowel obstruction and are dying. So the age group is also, it's coming down. For most of the cancers coming down, and colon also it's coming down.
Hello.
Yes, Dr. Ellis. Yes, Dr. Ellis.
This is a dietary habit like vegetarian, non-vegetarian, things like that. What a particular influence on this kind of cancer?
The general advice is, depending on what I told you, that dietary general advice that we are telling everybody, all the cancers. So basically now obesity is thought to be a risk factor for most of the cancers now, including breast, endometrium and all, because of the hormonal influence and the fat itself. Actually, the fat cells are sending signals down to for the cancer cells or tumor cells to divide. So obesity is a known risk factor for cancer now. So dietary advice that we give for everybody for preventing to have cancer mainly is the BMI target. So 18 to 23 our target BMI. Tell everybody to do regular exercises, 30 minutes exercises per day for 5 days a week, and cut down on red meat, cut down on all the the high energy food. So basically you have to follow the food plate. So less of carbohydrate, more of fruits and vegetables. The importance of fruits and vegetables in our diet, and that is very, very important, especially for colon cancer. So high fiber diet. The problem with the ones that has got low fiber is all the issues about constipation coming up in low fiber diet. Similar thing is with the colon cancer also. So diet is very important, and that should be high fiber diet. So more of vegetables, more of fruits, less of starchy materials and high energy ones, less of processed foods. So the barbecue meat, the red meat. The burgers, all those things, having more processed food, sugars, less of them, only the one that is needed, salt and sugar less. Whatever advice we give for a typical NCD, so typical hypertension diabetes patients, we give an NCD advice that has to be followed for the cancer patients also. So that is what we are sort of targeting to do in our population. And I think causing an obstruction causing on a cancer patient, same thing, any diet that can cause constipation probably will trigger obstruction. So these patients are prone for obstruction, right? So you should have more fluids and more fiber in your diet.
Thank you, Dr. Sunitha. Dr. Lillis, you have any more question to ask on?
No, thank you very much. Thank you for listening.
Thank you, ma'am. So anyone out there having any doubts on the patients you see on bowel obstructions? Dr. Sunitha, you have any updation to say on anything?
No, I think question number 4, what's the place of surgical intervention for removal of obstruction? Again, I think we have covered in the class, isn't it? So I've told you which all patients can go for surgery, or it's contraindicated. And yeah, I think that's it. So I think in this patient also probably because she presented late, it wasn't, that is why we couldn't do anything. And it's usually colon going to brain. Again, I think I haven't seen much patients, but it can go anywhere, isn't it? So she must have been quite unlucky. So it started February, and then by June, July, when she presented, it's already reached the fourth stage. So it has to be an aggressive cancer. So even if probably wouldn't have done, she might have done she could have bought a bit more time for her for the daughter's wedding if she had come earlier on. But it looks like an aggressive cancer. And I had some confusion about the medications. If you can go back to the medication slides, and I can understand which all, because all those are trade names. If you can tell me about those medications just for my interest.
Ma'am, 1 second, we will move on to medication slide. Yes. Ma'am, can you see it?
Yeah. So Pandrop, I know. What is Neomol? Oh, is it paracetamol?
Paracetamol IV. She had temperature 100
ml.
Yeah.
What's paracetamol? Neomol.
Yeah.
Okay. Siscan 150. Tap Siscan.
She had oral candidiasis, so we put antifungal, local, and tablet form.
Gluconosol. Okay. Orofa.
Orofa is iron.
It's an iron.
Oral
iron. Oh, okay.
She was anemic.
Piratas, I think, is tacicin, isn't it? Piperacillin tazobactam.
Yeah.
And why do you give Mesna nebulization? What's Mesna? Mesna,
She had breathing difficulty with the plum inside, So you put a bronchodilator plus this plum diluting.
Mesna is that the mucolytic one that we use?
Mucolytic. Together.
Okay. Yeah, that's fine. So yeah, that's all right then. So she didn't have much of a pain. You didn't need to give
Pardon?
any opioids then, did you? Pain was not an issue.
Pain was not an issue because she was almost unconscious.
And even antiemetic is not in the list. So was she not vomiting either?
You
put rice tube down
there. The first one day,
okay.
Not there. And she was not taking anything orally.
Okay. Yeah, so she was you put rice tube down. So then
that's on IV fluids.
Yeah. Okay. Yeah, that's fine. Yeah, nothing else from my part.
Okay, thank you for the instructions.
Madam, F. Colin and HIA.
That is
HI is human albumin.
insulin.
Oh, insulin.
Because
I trap it. Okay, okay.
she had a high blood sugar 225 like that on third day. Then always put it as that insulin in IV fluids.
No, but then what about the steroids?
Actually, her
It's called a steroid,
condition,
right?
there was no need. No, she was so calm and quiet. There was no anxiety, no complaint.
Okay. Oh, okay, okay.
Yeah.
Settled.
Last 6 weeks, given a lot because of pulmonary edema was there.
Yeah, okay. The only thing probably I would stop here would be the iron tablet, because it can cause constipation and
Yeah.
probably is not indicated in this stage of a disease.
Yeah,
So that's the only thing that I probably would stop. Yeah.
Okay, thank you. Thank you.
Okay.
But can we do iron parenteral in this case?
What was the hemoglobin?
8.38 it was. For blood
I'm not
transfusion
very
and all
convinced
patient
about the
was
iron parenteral. Yeah, to get symptomatic benefit with parental iron, I'm not entirely sure. But it's because it's definitely has to be an iron deficiency anemia, isn't it? We have to do the iron level and then definitely find it's iron deficiency anemia. And then an iron, I think infusion has got this anaphylaxis risk and all. So if you want to give her something, and if she's symptomatic with the anemia, then probably go with blood transfusion. And if it works or not. So the question is whether she is symptomatic with the anemia or not. Is she actually bleeding? And if she's dyspneic, and if she's not symptomatic with that anemia, I wouldn't do anything, because the iron has to replace the iron store for to become the hemoglobin, right? So it might not give her much benefit immediately. So for symptom management purpose, maybe that's not indicated.
Okay then.
Okay.
Thank you, Dr. Sunitha, for the excellent presentation. And sorry from our part, we had an immense of technical issues this time. So we'll make sure that we will come up with no technical issue from next class onwards. Thank you, Dr. Lellis, for the case presentation.
Thanks, Rajashmi.
Thank you, ma'am. So we can see you on next Monday with a topic on respiratory symptoms taken by Dr. Pankaj. So I've shared the feedback link. So give it a minute and do it, and then leave the meeting. So see you all next Monday. Thank you all for joining
Okay, thank you very much.
in.